All right. Good morning, everyone. Sorry to keep all of you waiting. I've been asked by Garima and Ramesh to give a talk on fetal cardiology. What initially transpired to be just a talk, we will expand it to about 4 or 5 talks over the next couple of weeks to months. So I will give just a general overview of fetal cardiology and the various aspects of it. And in the subsequent weeks, we will talk more about the various abnormalities of the 4 chambers, of the outflow tracts, of rhythm, of function, as well as newer advances, and finally involving the counseling, the cardiac nurse specialist, as well as the hospice team as well. So let me start this off. So as I said, I'll give an overview of screening for fetal in terms of fetal cardiology wise, normal versus abnormal structures, function, rhythm, management and multidisciplinary team management of patients, as well as intervention and newer advances. So if we talk about congenital cardiac anomalies, as you all know, the incidence of congenital heart disease in live births can vary anywhere between sort of 4 to close to sort of 20 per 1,000 live births. But if you actually look at fetuses, the percentage is a lot higher, partly because either those who have congenital cardiac anomalies are severe enough that they have a spontaneous in utero demise before it's even diagnosed, or they have associated also chromosomal or extra cardiac anomalies that may make them non-viable, and therefore they do not survive to birth to be counted as a congenital heart disease. So all of you will know that congenital cardiac anomalies can range from very mild problems on the left-hand side of the screen, PDAs, ASDs, VSDs. VSDs can be quite small or they can be quite large, and then it can go on to coarctations of aorta, TGAs, tetralogies, AVSDs, to the other end of severe spectrum on the right-hand side of the screen, where you have one side of the heart missing, either the right or the left side of the heart missing, hypoplastic left heart, tricuspid atresia, or pulmonary atresia. So as I said earlier on, the incidence or prevalence of congenital heart disease varies between the antenatal and the postnatal population. So if you manage to catch all the antenatal sort of patients with small hearts, either on the right or on the left itself, you find that they are a lot higher, anywhere between 15 to 17%, whereas the prevalence is much lower, between sort of 3 to 10% in the postnatal group. The same goes for AVSDs, double outlet right ventricles, and so on and so forth as well. So what is the cause? Broadly, we talk about chromosomal defects. It occurs in approximately 6% of all congenital heart disease, but my data that I've gotten is relatively old. So with newer sort of microarrays and whole exome genome sequencing and whatnot, you'll find that chromosomal defects account for a slightly higher percentage than the previously known 6 to 10% of all congenital heart disease. We always say is that if you have only the heart, there is a possibility of congenital heart of chromosomal defect. But if you have the heart and other things, then it's more part of a syndrome or chromosomal problem, and therefore this issue of multiple genetic abnormalities or part of syndrome need to be considered. For example, things like Hall-Oram or Vectoral association. Yeah, excuse me for a while.
Started. All I was going to say was this girl,
yeah,
we have got her anaesthetized,
yeah,
but she needs psychological input
in the future,
because we thought we could give her a pre-med, but she's wise to that now. So she's
not having it. So what's happening then?
So she is having it.
Yeah.
Because Mum wants us to carry on because she's so worried.
But the future, we might need to sort something out.
So you need, from now on,
I will let whoever know.
She needs
lots more. Lorna.
She needs a lot more help.
All right. Okay. Fine. Yeah.
Now,
I will let whoever the consultant is know. Good. Thanks. Sorry, excuse me. So we also need to consider environment factors like infections, maternal diseases. For example, moms with poorly controlled diabetes may have an increased risk of congenital cardiac anomalies as well. But the majority of the cases, we tell the parents between 60 to 70% of the cases is just pure bad luck, not what they have done, not done, what they've eaten or not eaten. So, and this is especially important for all the parents because they will find any possible cause. They forgot to take their prenatal vitamins, or they walked across a field with cows. Therefore, they had a child with a cardiac problem. So we need to reassure them that in most cases it is not. So what about recurrence risk? This is a frequent question that parents ask us as soon as you make an antenatal cardiac diagnosis, and not infrequently in the postnatal diagnosis groups as well. Generally, if a first-degree relative is affected, then future pregnancy risk of congenital heart disease is double the population risk. So if the population risk is 0.5%, 1 in 200, it becomes 1 in 100, and it can range from anything as minor as a tiny hole in the heart to something as severe. What about recurrence of the same defect in affected families? Well, with increasing genetics and microarray that is being done, it's becoming more clear that actually the recurrence of same defects is more common than you think, especially things like heterotaxy or isomerisms in studies in the East, where it is more prevalent, for example, in Taiwan and in Asia. The relative risk of a recurrence is close to 80%. For conotruncal anomalies, your truncuses and whatnot, relative risk is 12%. And for right and left ventricular outflow tract obstructions, it's actually quite significant as well, anywhere between 10 to 50%. Overall, the recurrence of the same defect in the families is about 8% if you take into account all congenital cardiac disease. And the main factor for recurrence of the same type of congenital heart disease can be attributed to inheritance of a single gene mutation. And as I said, with more advanced genetics that we have now, we're able to find out more and more about such problems. So what about in twins? Congenital heart disease is actually more common in twins than in singletons. I'm not sure whether any of you have been party to some of the twins that we have seen over the years, where one twin may have a hypoplastic arch, the other one may have an interrupted arch, or one may have a tetralogy and the other one has a tetralogy pulmonary atresia sort of picture. But generally, if you are a dizygotic twin, versus monochorionic diamniotic, so MCDA, versus a monochorionic monoamniotic twin, you will have higher degree of concordance, but there can be different reasons to the discordance between the types of the twins itself. You can read in this paper by Heskin in Circulation 2013 if you want to know more about this. So what about cardiac screening? Let's go back to cardiac screening. So indications for cardiac screening includes a family history of congenital heart disease. As I said, if a previous child or one of the parents is affected, then you want to screen for the affected fetus or the potentially affected fetus. If you have left or right obstructive cardiac lesions, so as I said, the recurrence risks for the same cardiac lesion, you will want to sort of look for that. If there is a chromosomal abnormality for a definite chromosomal abnormality like 22q11 deletion, then it should be screened, especially if mom has it, then as at least 50% risk that the child may have carried the mutation as well. So maternal risk factors, if mom or dad has the congenital heart disease, then the child should be screened as well. If there's maternal disease like anti-Ro, anti-La antibodies, or known parvovirus or rubella infection in mom during the early stages of pregnancy itself, then the fetus should be screened. If mom is exposed to teratogens, we are all very much guilty of keeping our patients or female patients on ACE inhibitors, on warfarins and whatnot. And these are potentially teratogenic if is taken throughout the pregnancy, but we need to weigh the relative pros and cons of these medications versus the potential risk to the fetus itself. So other risk factors in terms of fetus itself, if there's fetal hydrops, you need to find out why. Is it a structural problem? Is it a rhythm problem? Or is it a function problem? If there's abnormal cardiac rhythms, they indicated for cardiac screening. Increase in nuchal translucency. I'm not sure whether any of you, or I think most of you would have sort of known about this nuchal translucency, which is a thickness of skin behind the neck itself. And if it's above a certain dimension, so more than 3.5 millimeters at around 10 to 12 weeks gestation screening, then it's a marker for potential chromosomal and or congenital cardiac disease. If you know that there's extra cardiac anomalies like omphalocele, diaphragmatic hernias, or duodenal atresias, then you want to sort of make sure that you look out for potential heart issues as well. As I said, it might be part of a syndrome. So what has happened over the years in the UK? So particularly in England, over the years 2002 to 2008, we have seen that from a previous only 4-chamber views being used, we are seeing that more and more outflow tracts have been introduced. So when I mean outflow tracts, I mean the right and the left outflow tracts, the aortic outflow as well as pulmonary outflow. So some structures of the heart, for example, if you have a tetralogy of Fallot, the 4 chambers can look relatively normal if you miss the VSD, but it's actually the outflow tracts that look smaller on the pulmonary artery side. For example, your TGA as well, the 4 chambers may look absolutely normal, but it's your great arteries that come out that look parallel or they come out the wrong way. So over the years, you can see that in 2008, Northwest at the bottom on the left-hand side, that has only about 66% outflow tracts that were offered in 2008, but we are getting close to 80 to 90% in the recent years. East of England and London itself, well, they have quite sort of quite more heavily sort of invested services. So they're doing quite a lot better even in 2008. So let's talk about fetal cardiology screening. There are 2 types of screening. The ones that are commonly done throughout the UK is the 18 to 20 week typical anomaly screening. And that's done by all obstetric units in the UK. And if they find that there is an abnormality either of the heart or any other part of the fetus itself, then they would refer to the appropriate fetal medicine unit. And if it's a cardiac question, then they will refer to the fetal cardiac unit for further evaluation. And then there is the earlier one done at between 12 to 16 weeks, and that is usually done by obstetricians for high-risk cases. So if you know that there's increase in nuchal translucency, or you find that actually the child is already hydropic at that time, then obviously the obstetricians will be the ones reviewing this. But there's increasing call by the worldwide fetal cardiology community that the fetal cardiologist should be starting to look at fetuses at around 12 to 16 weeks as well, because the pickup rate is slightly higher, but not fraught with problems. So let's talk about the first trimester screening between 6 to 13 weeks. As I said, it is increasingly being used in more and more units around the world. But as I said, it is not a routine in the UK at this point in time. And the reason for this first trimester screening being more and more possible is because we have now higher resolution machines, and also technically the fetal cardiologists and the fetal cardiac sonographers are getting better. So you're able to recognize anomalies at a much earlier gestation. And as I said, they are mainly fetuses with increased nuchal translucency, or there's an abnormal karyotype, or there's a family history of congenital heart disease. For those of you who have dealt with patients postnatally, you know that if the parents have lost a child at a very early in the early neonatal period, or even within the first couple of years of life, when they plan for the next pregnancy, moms and dads are usually a bunch of nerves, and they can't get really reassured until they see for themselves the fetus has no similar cardiac condition. So to wait 20 weeks may seem very short for some people, but for if you're pregnant with the next child, 20 weeks is a long time. As I said earlier, limitations include limitations of equipment and skill. So you need sort of very good high resolution machines to be used in order to be able to see such tiny structures at 13 to 14 weeks. Whatever it is that you do not make a confirmatory diagnosis or a confident diagnosis at the 13-14 week scan. You will always need confirmation at 18 to 20 weeks. Reason being is that the heart is, as much as is fully formed already, you might miss smaller structures, you might miss VSDs just because the pixels that you're getting on your echo machines may be larger than any holes that is being seen in the fetus. And also there's a potential of progression of any cardiac lesion that you see. What may be not narrowed at 13-14 weeks may become narrower at 18 to 20 weeks or in later gestation. But the benefits are quite huge. It can potentially reduce anxiety levels of parents, especially with previously seriously affected child. But remember, just because you want to allay the fears of parents, you need to be absolutely confident that you can do it, and you can be confident enough that you are seeing what you need to see. So false reassurance is equally as bad as no reassurance at all. So this is a sort of a slide from Professor Nicolaides, where he has sort of proposed that actually previously we might be only diagnosing most of the cardiac lesions towards the later part of the gestation or after birth. But now what we are seeing is that you're seeing more and more of the fetuses being diagnosed antenatally, either at the early first or late first trimester, early second trimester, and leaving hopefully fewer patients to be diagnosed postnatally. Is it a good or a bad thing? You have to ask yourself that question. So what has changed over the years in the UK? So as I alluded to earlier, previously we were doing only 4 chambers, but more recently in 2008, we increased it to outflow tracts. And then in 2010 towards 2012, we did 5-chamber cardiac views accompanied by the outflow tract. So those of you who have been to the fetal cardiac clinic will know that we mentioned this 3VT view. Basically, it's 3-vessel trachea view, which incorporates the outflow tracts. So how have we done then in these areas? So if you look at the slide on the left-hand side of the screen, between 2004 to 2007, if you look at the circle, which is where Liverpool is, the dark blue right in the center here, it's close to about 5 to 15%, depending on the slightly darker shade of blue. And then as you go to 2006 to 2011, the area that is dark blue is becoming smaller and is becoming lighter blue. And in fact, in some areas, it is close to a red, which is about 40 to 50% pickup rate. So we are definitely getting better. Unfortunately, I do not have any more recent data than that, as NICOR and the FAST has not updated the data since 2011. So Northwest again, if you look at just North Wales and Northwest itself, and between 2013 to 2016, we are the sort of green and brown and blue. And in 2015 and 16, we are more sort of bluish rather than the brown. So we are definitely getting better. NICOR data, more of the same. Again, hypoplastic left hearts over the years, it's been pretty good antenatally diagnosed. TGAs, because of the outflow tract anomalies, the 3VT views that have been implemented, you can see that early on is about 25 to 30%. Now it's close to 50%. We can only hope that we can get close to 80, 90%, but I think to get 100% diagnosis for any of these things, it's near impossible. So what about older hay patients, which may be of interest to all of us? Over the years, as I have shown in a previous slide, in a previous meeting, over the years, we have had more and more cardiac anomalies that are diagnosed over the years. So in 2008, we diagnosed only about between 50 to 60. And now in the recent years, we have plateaued between 140 and 160 cardiac anomalies a year, which is actually almost double to triple what we did in 2008. So what about TGA patients? TGA with no VSDs between 2001 to 2018. We have a steady sort of numbers over the years. It's usually between sort of 20 and 25. And as you can see, the postnatal ones are the red and the antenatal ones are blue. And over the years from 2001 till 2008, you can see that there's increasing trend of the antenatal diagnosis, and we are getting more and more of those TGAs that are diagnosed antenatally. So I think we're definitely getting better. What about truncuses and TGAs? So before the outflow tract views were noted to be mandatory, we had decimal 12.5% and 17 or 18% for truncus. And since the outflow tracts were mandatory, we have gone up from 12.5 to 32%. This is way back from 2012. So we are much better now. We're close to 50% for TGAs. And truncuses from 18%, you've gone up to 50%. I don't have any more recent data. So any of the trainees who are keen to help do a re-audit would be, I would gladly accept them. What about unbalanced ventricles? So unbalanced ventricles, well, in many ways easier to note because it's 4 chambers. If you see one chamber smaller than the other, it's quite obvious. Obviously, the borderline cases are still a bit tricky. So from our data between 2001 and 2007, I know it's 13 years old. We had 325 patients, and we had data from Liverpool Women's as well as St. Mary's. And we found that actually we managed to diagnose quite a significant proportion of these antenatally. And the outcomes, irrespective of whether you were detected at Liverpool Women's or St. Mary's Hospital, was pretty much similar. A proportion of them, approximately about 40 to 50%, would decide for termination, whereas the other 40, 50% would be born alive. Why I say that it's important that Liverpool Women's and St. Mary's have similar outcomes, although they are based in different cities. Liverpool has predominantly of a Catholic population, whereas St. Mary's cover a predominantly ethnic Asian population, and you would think that there would be a difference in these two groups, but fortunately or unfortunately, it is interesting to see that actually because of the variation in population and the ethnicity and the religious beliefs, it has not changed what the outcomes have been in these two separate centers. So now we go to what a normal fetal heart looks like when we do see them in the fetal cardiac unit. So in order to detect abnormal, one needs to know what is normal first. So the things that we are looking for, as I said earlier, are the 4-chamber outflow tract anomalies. I'm not going to go into detail with this, but I want to make an emphasis that there are limitations to antenatal diagnosis. As good as all the fetal cardiac units are, if the fetal sonographer who does the 18 to 20 week scan does not suspect that there is a cardiac anomaly, so either they have not been trained adequately to look at outflow tracts and 3VTs, or they are in a rush, or mom doesn't attend the fetal anomaly screening, then they will not be referred, and therefore the cardiac diagnosis will not be made. If not, we frequently tell the parents that ASDs, PDAs, tiny holes, minor leaky valves, and bicuspid aortic valves cannot be seen. You can imagine the fetus is at 18 to 20 weeks is not big. So the aortic valve is at most about 2 to 3 millimeters. So trying to decipher whether it's a bicuspid aortic valve or not is very difficult. And similarly, total or partial anomalous veins is very difficult to pick up at 18 to 20 weeks, especially if you have an otherwise structurally normal heart. But if you have unbalanced ventricles, or you have associated double outlet right ventricle or possible isomerism, then we will obviously look harder. And not infrequently or increasingly, we are able to make a diagnosis of possible partial or total anomalous pulmonary veins. And if you're interested in future talks, we will talk about how we sort of pick that up antenatally. Obviously, it's impossible to look out for anomalous coronary arteries like L-Kappa in the antenatal period. We are also unable to reassure parents, especially in terms of inherited cardiac conditions like hypertrophic cardiomyopathy or dilated cardiomyopathy, which may present in later life. So although it may reassure some parents, it doesn't give them 100% reassurance that their child will not have the same manifestation as their other siblings who are older. As I said, if you see them too early at about 13, 14 weeks, you are limited by the quality of your machine as well as your experience in doing early scans. But if you see them too late, anywhere above sort of 34, 35 weeks, and especially if you have a rather big mother, then we may be limited because of the fetal size, their bones and arms and legs and all that in the way, and therefore it may make the viewing of the cardiac structure quite challenging. I've already mentioned about maternal body habitus. The next one is inherited cardiac rhythm issues like long QT and Brugada. As much as we can try to rule out that there's no bradycardia, no cardiomyopathy, unfortunately, unless you know the genetics, unless you know that mom has a problem, it is very difficult to make an antenatal diagnosis. So when we do see the patients, then in a dedicated fetal cardiac unit, you would try to look at the heart in 5 standard planes. So you look at the situs. So it is important to know that left is left. So I'm not sure whether Sophia is around, but she found it quite challenging when trying to orientate between where the head of the fetus is, where the spine is, where the arms and legs are, and to sort of see whether the spine is facing up, facing down, whether left of the fetus is actually left that you see. So the stomach and the heart should be on the same side, and it should be on the left-hand side in 99.99% of patients that you see. But it can equally be on the right-hand side with the heart on the right, and you'll be no wiser if you have not sort of found out where your right and left is. So that's the first view, situs view. And then as you pan further up to the head of the fetus, you then see the 4-chamber view. I will go into more detail in a short while. And then you then first see the left ventricular outflow tract, and then followed by the right ventricular outflow tract. So these two views, the outflow tract views, they should what we call cross over. And if they do not cross over, then you become suspicious that the child might have transposition of great arteries. And then finally, the 5th plane, you look at the 3VT view. So it's like a little, it's like a pointy sort of pyramid. It should all form into a tip of a triangle here. So that's a typical 3VT view. And if this is not seen, or you only see 2 vessels, or is arranged in an unusual way, then you start worrying that there might be some anomaly that you have not picked up. So this is just looking at it another view. So situs, 4 chambers, left outflow, right outflow, followed by a 3VT view. So I will not go into detail with this. So what do you see in the normal four chamber? So as I said, situs, stomach has to be on the left. The heart has to be heart has to be placed in the left, with the apex pointing to the left itself. The axis should be about 45 degrees, not more, not less. Okay. The 3VT view. So PA aorta SVC, or ductal arch aorta SVC, and the trachea is right in the center here. All right, so situs view. So left, right of the situs of the fetus is very important because then you know where the liver is, where the stomach is, and this is especially important if you then start sort of making a diagnosis of possible isomerism or heterotaxy. The heart should be on the left. If the heart is pointing apex to the right itself, then you have to worry, have you sort of confused your right left, or is it true dextrocardia? You can talk about, is it more of an isolated cardiac is it associated, does it have associated cardiac defects like or not? Is it isolated dextrocardia, or is it situs inversus with levocardia, or is the heart just basically in the midline, right in the center, with the apex pointing centrally, or is it that the heart is still pointing to the left, but it is displaced to the right because of a structure or mass that is occupying the left-hand side? And the most common thing is a left diaphragmatic hernia. Equally, the heart could be displaced to the right with no diaphragmatic hernia if you have agenesis of the right lung. So the lung is not there, and therefore it doesn't occupy a space. And the left lung is basically a bit overinflated. So everything is shifted to the right itself. Similarly, the heart can be pushed more to the left because of a right diaphragmatic hernia or right mass or agenesis of the left lung. So the fetal heart position is very important to start off with. So, and then you need to make sure that the stomach is filled, the aorta is to the left of the spine, the liver is to the right of the spine, the IVC is there, it is to the right of the spine, and it is a bit at the same level or a bit posterior to the aorta. If it is not, then you start being suspicious that is it isomerism, is it interrupted IVC? And you should also make sure, as you would do in a postnatal scan, that the IVC and hepatic veins are connected and they then join into the right atrium. So if you have any situs issues, usually it comes in the question of, is the stomach and the liver on the wrong side? Absent of multiple spleens, well, most of us struggle to find spleens, and most of the obstetricians struggle to find spleens as well. So I wouldn't expect you to make the diagnosis of multiple spleens or absent spleens. You need to sort of have a clue of where the IVC and aorta are and whether the IVC is interrupted or not. So this is the normal situs view. Again, let's go up. Okay, so the whole fetus, all right. Assuming then now the head of the fetus is towards you, you're sitting in front of the screen, and the legs and the dangly bits into the screen. The spine is at the bottom, so therefore the stomach is on the left. The aorta is on the left. That's the spine. That's the huge liver there. All right. And now, as you pan a bit more towards the face or the head of the fetus itself, you see the heart that is pointed to the left. The apex is pointing to the left. It occupies less than 50% of the whole thorax itself. It looks equal size, the right and left itself. You see the AV valves. You need to look at where the offset is. All right. That's the aorta. You see that the distance between the aorta and the back of the left atrium is very minimal, and that is normal. If there's increased distance in that, you start being suspicious that there is anomalous pulmonary veins. In this view, it is very difficult to see the IVC, but the IVC is somewhere around here. All right. So just various views. Is it situs solutus? Is it situs inversus? So that's the stomach on that side, but this is still a fetus that is the head in front of the screen and the feet at the bottom or into the screen itself. Right isomerism, you have the aorta. The IVC should be actually, the aorta should be on the left-hand side, the IVC should be behind, but the IVC is now anterior to it. The IVC is now side by side to the aorta. So this is all not normal. And if you were to then turn this into a sagittal plane, if you put some color Doppler, typically in most babies who have no interrupted IVC and no azygous continuation or hemiazygous continuation, you'll see only one vessel that is coming down and it's only one color. But if you see two parallel vessels, one that is red and one is blue, be suspicious that there is an interrupted IVC somewhere with hemiazygous or azygous continuation. So what about four-chamber view? As I said, apart from either after knowing where the situs is, this is normal. You look at the position of the heart, the cardiac axis, the size of the heart. As I said, it should be less than 50% or less than 40% ideally. How does it contract? What's the size of the right and left atrium? What's the size of the right and left ventricle? Are they both apex forming? Is it more trabeculated? Is it more hypertrophy on one side and the other? How is it related? Is it side by side, or is it looking funny with those upstairs, downstairs ventricles? What about the position of the tricuspid and mitral valves? Do they have normal offset? The tricuspid valve being more apically placed as compared to the mitral valve? Is there any sort of plastering of the tricuspid valve to the septum itself, as in Epstein's? Is it opening? Is it not opening? Is it equal size? Is it leaky? And then you go down to the interventricular septum. Is it intact? Is it not intact? Are there multiple holes? You put color on to make sure that there's no flow across that. The atrial septum, where is the PFO flap going? Is it going from right to left or left to right? I will let you ponder in the antenatal period, should it be the flow going from right atrium to left atrium, or should it be left atrium to right atrium? I'll ask you that at the end of the talk. You need to also look at the coronary sinus. That can be quite easily mistaken for a primum ASD if you're not careful. And you need to make sure that there's at least one pulmonary vein on each side going into the left atrium, and there's indeed pulmonary venous connection to the left atrium itself. So what are the limitations and pitfalls when you look at a four-chamber view? Obviously, if you are trying to look at the perimembranous region of the ventricular septum itself, you might miss it occasionally depending on which plane or which direction of the plane itself that you are seeing, because it's very thin, and you might actually misdiagnose or overdiagnose a perimembranous VSD. Some people think that they might confuse a dilated esophagus because the child is swallowing versus a possibility of a pulmonary venous confluence. They can see tiny amounts of fluid around baby's heart itself, which is quite normal if it's less than 2-3 millimeters. But obviously, if it is more extensive and you see it elsewhere, then it's a cause for concern. So as I said earlier on, pulmonary veins, you should see at least one right and one left entering the left atrium. There should be close proximity between the left atrium and the descending aorta. If there's increase in distance, then you worry about anomalous pulmonary veins. What about left ventricular outflow tract view? So we have finished with four chambers. So as you pan a bit more towards the head of the fetus, you then see the left ventricular outflow tract. This is no different from the views that you see postnatally, so-called our parasternal long axis view or our five-chamber view. So you should see a nice size, nice flow across it. You should measure the size of the aortic valve. Make sure the valve leaflets are opening. But as I said, it is impossible to diagnose, almost near impossible to diagnose a bicuspid aortic valve. And then when you go into as you go more towards the head of the fetus, then you see the right ventricular outflow tract. So this is like your personal long axis if you're pointing towards the RVOT. So again, making sure that there's flow across it, you put color across it, making sure that the size is similar to the LV outflow tract, making sure that the leaflets are not thickened, doming, or dysplastic, so that you know that it is of a similar size to the to the left-hand side. So this is a checklist again, as I mentioned earlier on, and clues for abnormalities include that if they don't cross over, they are different size, they're just placed in a different position, or things look thickened, and when you put color, they don't go in the correct direction, they're going backwards, or you can hardly see any flow across it. So then the newer 3VT view, over here, the the ductal arch, the aortic arch, and the SVC here. You should see a normal course. They should be all approximately equal size, with the pulmonary artery or the ductal arch being the slightly larger one, the aorta being slightly smaller, than SVC being the smallest. Occasionally, you can pick up also a left SVC or bilateral SVCs as well. There are further clues to abnormalities. If you see one that is bigger than the other, you only see two vessels rather than three. Either they're aligned in an unusual way, a U shape rather than a normal sort of pyramidal sort of V shape. They might have different directions to flow. You might have additional vessels there, like your left SVC or bilateral SVC. So variations in 3VT, you have your ductal arch, and then you have aorta, you have your right SVC, that is the left SVC. So it's important to know where your right and left are, so you know whether you have two SVCs or one SVC. So I'll then quickly go to fetal heart rhythm issues. It is concern for some fetuses if the heart rate goes too fast or too slow, and occurs in approximately about 1 to 2% of pregnancies. They can present either with irregular heartbeats because the midwife has put a Doppler on mom's belly and noted that it goes boom, 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 or goes boom, 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 or goes boom, boom, boom. But what is important, a midwife has to listen over a 2 to 3 minute period rather than plop on, get a count, and go off. So practically, apart from the Dopplers that the midwives use, when we see them at the fetal cardiac unit, we would have a look on either the 4-chamber outflow tract views, get an actual Doppler across it, and also do some M modes as well. So we analyze the rate, the rhythm, whether it's regular, irregular, it is sustained, or is it intermittent. So it's important that when you see a fetus with a query heart rhythm problem, you measure the heart rhythm at the start, you measure at the middle, whilst doing the rest of the anatomy, and then towards the end again. So you look at it over a period of 10-15 minutes rather than just over the first 2 minutes of your review. And if it is regular, irregular, is there block? Is there a 1-to-1 conduction if it's very fast? Or is it 2-to-1 conduction? Is it 3-to-1 conduction? Or is there no correlation at all between the atrioventricular rate? So we're sort of trying to do an ECG on the fetus, but not really, because it is impossible to do a fetal ECG in most cases. In some centers where they have the facilities, it has been done, but it is very, very time consuming. And after sort of diagnosing the heart rhythm problem, we also need to sort of make sure that there are no underlying structural or functional cause for it. So, for example, if you have CCTG or isomerisms, you might be associated with a slow heart rate. If you have a mass effect, either for an external mass or within the cavity of the heart itself, for example, rhabdomyomas or fibromas or other form of masses, it might irritate the heart, and therefore you might lead to cardiac rhythm problems. If you have cardiomyopathy, poorly functioning heart and whatnot, the heart rhythm might be quite irregular and quite unusual. Also, think of electrical causes. The long QTs, Brugada sometimes do present with bradycardia or tachyarrhythmias in fetal life. SVTs, as you would see, for various reasons, either of various causes of SVTs may present in antenatal life with fetal heart rhythm issues. And for families or mums who know that they are anti-Ro, anti-La antibody positive itself, they may or may not have associated connective tissue symptoms. They may present with fetuses with a complete heart block or impaired function on the left-hand side itself. So when you're assessing the heart rhythm, it's not just the rhythm that you look out for the underlying cause of it, and also the secondary effect of the arrhythmia. With prolonged sustained arrhythmias, you can have AV valve regurgitation, you can have impaired cardiac function, you can start having effusion around the heart, around the lungs, you can have around the belly itself, and you can lead eventually to hydrops. And in very unfortunate cases, it might lead to in utero fetal demise. So how do we assess fetal heart rhythms? We put a Doppler across any of the valves itself or any outflow tracts and put it over a few minutes and see what the heart rate is. So you can count the V rate. So this is the aortic outflow. So depending on your machine, sometimes it's between 2 heartbeats, sometimes it's between 3 heartbeats to give you an idea of what the heart rate is. But as you can see, this is quite regular. So there are some that you can see quite a lot of spaces in between before it becomes regular. So it gives you an idea of not just a rate, but the rhythm itself. So you can pulse the Doppler at just across any valve itself that you want. If you wanted intervals, you can interrogate the SVC and the aorta simultaneously, or you can interrogate between the mitral inflow and the aortic outflow simultaneously. This I will talk about in more detail when we give the fetal rhythm abnormality talk. So SVC aorta Doppler, we'll talk about a bit more detail in the rhythm talk again, as I said. Mitral inflow, outflow, you can get AV intervals and whatnot. M modes, basically not unlike what we do postnatally. What you need to do is you need to get a line between the atrium and the ventricle, and this is the atrial boom and this is the ventricle bump. So if you have A followed by V, A followed by V, then there is one-to-one conduction. So sometimes if you have complete heart block, you will find that the A is beating independently of the V. You can actually get rates, fetal heart rates of fetal atrial rates and versus fetal ventricular rates, and you will find that they might be similar or dissimilar. So more about irregular fetal heart rhythm. So as you can see here, you have lots of beats in the atrial sort of wall itself, and then the ventricular walls. Yes, it is conducting. This is a premature atrial beat and is then not conducted, so it comes back a bit later. Ventricular ectopics, you see AV, AV, and then there is no A, and then suddenly you have a premature ventricular contraction before that. And in this particular fetus, it was because of a mass within the left ventricle itself. M mode again, more details, blocked atrial ectopics. So I want to then briefly go into patient management. So roughly most fetuses would be seen at least twice, if not 3 times during the pregnancy, as soon as they have been referred to us between the 18 to 20 weeks up to about the 40-week gestation. Different units obviously do things slightly differently. There are some units who will see patients for three visits, irrespective of whatever the underlying cardiac condition is. I think we need to weigh the pros and cons for all this, including capacity as well as demand for the limited fetal cardiac slots. but that is a separate topic to be discussed. And ideally, apart from the fetal cardiologist looking at the heart itself, it would be useful if the fetal medicine specialist were to review the rest of the anatomy. As I said, some cardiac structures abnormalities do not exist on its own. It might be part of a genetic problem. It might be part of a syndrome. So there might be other issues that might be missed if you do not look at the rest of the heart. The rest of the baby. And finally, as part of management, we would offer amniocentesis, and microarray is now part of the routine test for all amniocentesis that are done in the UK. And it can be done either at the time of the visit or at a later time if parents need more time to think. So basically, after making the diagnosis, you would want to explain things to the parents, you want to give them options, and you want to document things as clearly as possible so that the referring unit, the GP, as well as the parents know what's happening. Because, things are rather overwhelming when you have a significant cardiac lesion that's been diagnosed. We also provide them with cardiac books, cardiac handouts. You know, you have seen this Heart Children's book, you have seen this antenatal information pack, you have seen this Little Heart Matters booklet that has been handed out to parents and families as well. Very much invaluable to as part of the service is the cardiac nurse specialist involvement, because they sort of act as a link between the diagnosis and the consultant who makes a diagnosis as well as the parents, because parents will have lots more questions when they leave the hospital, and to wait 6 to 8 weeks or to have to call you over the phone, and it's a bit challenging for some parents. So having someone that they can sort of contact at their leisure, and someone that would sort of have a lot more time for them, it's very much helpful. Obviously, we will also organize for all the hay visits. You would have seen Jill and Marie having the HoloLens, walking around the hospital, taking parents for visits around the hospital in order to prepare them better when they come to be born, and to be transferred to all the hay for further management in the future. Not infrequently, other teams are involved. The neonatal team is also involved, especially with complex cardiac lesions that may not necessarily go to plan. If they have associated other issues like diaphragmatic hernias and whatnot, the general surgical team is also involved. If they have associated brain issues, cleft issues and whatnot, then other teams are involved. And increasingly, we are getting the palliative care, or we like to prefer to word them as hospice team, especially for families where they have fetus with a significant cardiac condition that may have multiple comorbidities or may potentially go down the single ventricle route. And the palliative care teams have been very supportive of this, and I think most families have found that this has been actually very useful as well. So, brief summary: making diagnosis, after making the diagnosis, what we counsel them when we do counsel them is that it is potentially difficult to predict accurately what the potential clinical cause would be antenatally, because what could be just a mild aortic stenosis at 20 weeks may progress to become significant aortic stenosis and or may become hypoplastic left heart towards the end of the pregnancy itself. And even for tetralogies, although things may go all right, the pulmonary arteries may grow all right, it is difficult to guarantee them that this child will only ever have one surgery in the child's lifetime and may not need other surgeries in the future. And in a lot of these situations, parents find that it is actually quite difficult to get their head around, what their perfect pregnancy was initially. We have now turned it upside down and created so much chaos and concern for them that it's difficult for them to picture what the life of their future child would be like, especially if you have single ventricles or complex lesions with multiple extracardiac anomalies as well. So we give them options about the pregnancy itself, whether they want to continue the pregnancy or not. And if they do continue the pregnancy, would it be active surgical management or would it be compassionate care? And if they decide that they did not want to continue with the pregnancy, would it be simple termination if it's less than 21 weeks, or is it termination following a feticide as well? So lots of things for the parents to consider. And we try to get as many teams involved as possible during the counseling, but we try not to overwhelm them during the first visit. It's usually the second and third visits that we get more teams involved once we are sure that they are actually going ahead with the pregnancy. So I'll just rush around. So basically, this is a flow chart. You diagnose, you counsel them, you review them again because things can progress. And then you plan for delivery. We also usually tell them that if the baby is born premature or if the child is born at term, but a tiny size, small size, less than 2.5 kilos, or have associated chromosome or extra cardiac issues, then the overall outcome, whatever the underlying condition is, will be worse. And then we tell them that postnatally, although we have an immediate postnatal plan, things need to be confirmed again after the child is born with a postnatal echo, plus minus a few other investigations, including a CT or MRI, if that's indicated, before we make a decision whether it's something that's suitable for active management or we need to go down the compassionate care route. So as I said again, cardiac lesions, it is difficult to predict in entire accuracy what will happen for a particular cardiac lesion. Things can improve. We never tell the parents that it's all doom and gloom. There's always scope for some improvement, no change, or maybe things might get worse. We can't sort of be negative to all parents. We have to be encouraging for in most cases as well. And we need also to emphasize that sometimes, with subsequent visits, we can find more things wrong, and we can also find more things wrong at birth as well. And to try to give them possible scenarios if things improve, don't change, or deteriorate. And then obviously the extra cardiac side of things, to sort of get the other teams involved if they are things like diaphragmatic hernias, duodenal atresia, and all the rest of the stuff. What is important is that we see them at 6 to 8 week intervals, so that we can see a change. Seeing that at weekly or 2 weekly intervals defeats the purpose, because structures don't grow that quickly. And if you make a 0.1 millimeter change detection a week down the line, is it going to mean much difference to the fetus or not? So as I said, again, complicating issues, prematurity, if the baby is small, if there are extra cardiac issues, if there are chromosomal issues, and not infrequently, we see babies that are part of a multiple pregnancy. So if you have one twin that is normal and one twin that has hypoplastic left heart syndrome, obviously then the challenges for the parents are increased, because as much as for some parents, they might decide that they would not want to continue with the pregnancy. For multiple pregnancies, in order to stop one pregnancy early, it might put the other twin at risk. So these are the questions that we need to sort of put forward to the parents and to discuss with them before they can make an informed decision on what they want. I will talk about this in more detail under the session on counseling and management in the next few talks. So as I said earlier, we do not work independently. As the fetal cardiologist, we get the fetal medicine consultant involved, we get a neonatal team involved, we get the pediatric and obstetric team involved in district general hospitals if they are planning to deliver there. If there are extra cardiac issues, we get the relevant teams involved. We get a hospice, a palliative care team involved. The cardiac nurse specialists and specialist midwives obviously involved from the onset as well. And when we make the fetal cardiac diagnosis, we also try to assist as much as possible or to plan as much as possible the place of delivery. Some units will have babies with prostates, some units won't. Some units will not even have babies with AVSDs or rhythm issues. So you need to know what individual local units want. But apart from that, what parents want as well. So as much as some parents may want to deliver at a local hospital, if the local team is not happy to have them there, then it is not possible. Obviously there are also childcare issues and all the rest of the things that you need to consider. Usually we get the cardiac nurse specialist to sort that bit out for us. We like deliveries as close to term as possible, and if they are living far away, then we get them into Liverpool Women's, usually if it's Liverpool Women's patients, to be induced, and we would anticipate a normal vaginal delivery if at all possible. But if baby is stuck, baby is distressed, or mom is unable to push or any other reasons, then assisted delivery or cesarean section will be recommended. Obviously, if mums have diabetes, then it will need to be brought forward. If it's multiple pregnancies, it needs to also be brought forward from the 39 to 40 weeks. If there's already evidence of IUGR at 32, 33 weeks, then you need to sort of consider, is it worthwhile to keep the baby in with an increased risk of in utero demise, or should you then just give steroids to mature the lungs so that the delivery can be expedited? So questions, not straightforward sort of issues, but things that you need to discuss with the parents so that they have informed, they make an informed decision. And lastly, we then sort of tell them, do we need prostatin or do we not? What the acceptable saturations are, should they sort of keep them at the local hospital and then discuss with us, should we get them to do a local scan before they come to us or not? And how do we view the scans if they do that locally? And what the sort of postnatal course will be like. Amongst all this, we concentrate very much on the fetus. We need to know that mums are bundles of nerve as well. If not, the fathers are also very anxious. So let's not forget about the mums and the fathers as well. So as I said earlier on, options during pregnancy, either you continue or you stop. Unfortunately, there's a small proportion that will face in utero demise, irrespective of what the options the parents have chosen. So you need to warn the parents that if the fetus has been active and kicking and whatnot, and they notice that the fetus is less active or not moving as much, then to suspect that something is not right and they should go to the local hospital to get the fetus checked out. And then we talk about, do they want amniocentesis or do they want to defer that to postnatally if it does not change their overall decision making during the pregnancy itself. We provide all those information as documented here, and we try to take the parents' views as much as possible. We get them give them contact details because they usually have more questions after the clinic. The cardiac nurse specialist, I feel that has been invaluable to the service itself, and the other units who have cardiac nurse specialists in the fetal center have also noted that families tend to get better support during the pregnancies itself. And the fetal midwives are also important, especially for non-continuing pregnancies. We may know a lot about the fetus, but we don't know details of terminations, what happens after the termination itself, and what they do if they do a feticide and whatnot. So they have the most up-to-date information when it comes to those things. The usual parental predicament is that we can't give them 100% guarantee of what will happen, and parents want definite answers. When you see a borderline aortic arch with RV, LV disproportion, so the RV looks a bit bigger than the LV, you see them 20 weeks, you tell them that. You see them 28 weeks, you tell them it's the same thing. You see them 32 weeks or 34 weeks, you tell them the same thing. They go, yeah, you have not told us anything else new. But unfortunately, that's the case for some of these sort of patients. And luckily for us, a proportion of them postnatally, what we worry about being hypoplastic aortic arch turns out to be adequate. So things all have a happy ending, but not infrequently the suspicion of a hypoplastic arch or interruption comes through after birth, and surgery needs to be done. So it's difficult to reassure parents, because they will ask you, what do you think will happen to my child? And I never give them my personal impression of what I would do or would happen, because I always tell them that we can have a guess, and our guess is not always right, because each fetus is an individual, and each fetus will behave in a different way in terms of their hemodynamics itself. So it's difficult to give a definite answer to things. Whatever it is, we'll need a postnatal confirmation before we decide on management. Obviously, there are religious and social constraints. The Muslim community and the Catholics and the Jewish community may have certain preferences during the pregnancy itself, or certain preferences after the pregnancy itself. Also, if you have multiple pregnancies, if you have twins, triplets, then obviously the decision making becomes more complex. So a lot of you who work at Alder Hay would have seen this fetal cardiac report. I know it's very small, but basically what you need to know if you do sort of need to find the report on any of these patients is what's the diagnosis. You can read through the whole blurb of the cardiac findings if you want to, but that's the plan usually at the end of it, what we say they should do and what not. Obviously, it's not 100% foolproof. Sometimes the local units don't look at the most recent fetal cardiac report. They'll look at ones from the 20 weeks rather than the 32 weeks. So they need to know that things can change. They need to see the date of the report, which I've blanked out, sorry. That is the most recent one, so that the management is most up to date. So in summary, fetal congenital heart disease, it can only be made if it is referred to us. If we have abnormal four chambers, obviously look at the outflow tracts as well. Even if you have normal four chambers, always look at the outflow tracts. Remember that things may change with time. What may be looking normal at 20 weeks may look abnormal or more abnormal at 26, 28 weeks, or may look totally abnormal by the time the baby is born. So it's important, not to give 100% reassurance at the 20-week scan if you think that it is not quite totally normal. So finally, what's exciting for the future? Structure, as I said, more routine. Hopefully, we can do more routine early fetal cardiac screening in all units in the UK, not just in selected units. Hopefully, we can offer things like balloon, pulmonary, and aortic valves in more centers in the UK. Possibly stenting of restrictive ASDs in hypoplastic left hearts. I hear lots of people saying that, yeah, the outcomes are not that great. Obviously, there's a separate discussion to all this. We'll talk about it at another time. Question is, should we do fetal cardiac MRIs? To look for structural cardiac lesions, to look at aortic arches. Are they better than just the routine ultrasounds that we do? Would you do fetal lung MRI for prognostication purposes to look at nutmeg lung and hypoplastic left heart syndrome? Would that sort of, help parents make a diagnosis, make a decision that actually is really bad? They should really seriously consider compassionate care rather than try to push for active management postnatally. So these are questions that we would need to explore and to ascertain in the future. But it's interesting work coming up. As we can do postnatally tissue Dopplers, we can do tissue Dopplers for cardiac function in fetuses. So should this be a routine for all fetuses in the future? Possibility. In terms of rhythm issues, as simple as you think, fetal SVT management is, how many things can go wrong with a fetus? Well, you will find that there's a variation to what medications are used antenatally for fetal SVT. So there's an ongoing fast trial for the use of different medications, and hopefully we'll get an answer in the next couple of years on what's the best first line, second line, or third line management for fetal SVTs. Another interesting development is the use of hydroxychloroquine for prevention of fetal complete heart block in known anti-Ro, anti-La positive mothers. So should we routinely give these mothers at starting from about 8 to 10 weeks hydroxychloroquine so that they can reduce the risk of fetal heart block and cardiomyopathy in later life for such babies? It's a question that needs further discussion. So finally, the end, after a whistle-stop tour about fetal cardiac diagnosis, rhythm issues, counseling, as well as newer advances. So I'm sorry that it's gone very quickly. I've compacted as much as I can in that 1 hour. But if you stay glued to this series, you will find that in the next couple of weeks, you will see the subsequent sections of the fetal talks. Thank you.
Joyce, as Ramesh, yes. Thank you.
Yes, sorry, I've sort of packed in as much as I can.
No, you've done a fantastic job. I mean, I know we lost a few people for the last 10, 15 minutes just because they've got other commitments. But I mean, fantastic talk. I mean, you covered a huge range of topics and probably one of the best explanations as an introduction to fetal cardiology as I've heard anywhere. I think between yourself and the group, hats off to you for the work you do, because it's a tricky job with a lot of emotional and commitment and time commitment because of what you have to invest in the process. So now, a great job being done. Great job by the progression of the unit from low pickup rates to what looks like we're heading to excellent pickup rates for a lot of the conditions. So no, I think a great introduction to fetal cardiology and fetal medicine and the spectrum of it all, and really looking forward to the next few sessions that are being arranged by the group of the fetal group in the next month and month and a half.
Yeah.
Thank you.
Yeah, welcome. So if anyone wants to sort of ask me any more questions separately out of this, feel free to come and talk to me. Obviously, it's very difficult to try to sort of tell you in words on a PowerPoint slide rather than showing you live, what we actually do. So I would welcome anyone who want to come to the fetal cardiac clinics, but please let me know. It's one at a time just because of COVID restrictions. And also you have to understand that mums tend to be very anxious when they come. So, having 5-6 people looking at mums is not really the best idea, but please come either to Liverpool Women's, and I'm sure Caroline and Gordon will welcome you with open arms to St. Mary's as well if you wish to go over to the other side.
No, I'm sure they will take you up on that offer. I mean, and also, I mean, for anyone who's been listening, I think the talk was a great balance of kind of imaging and presentation slides and all. I mean, it was a great for discussing as broad and as difficult a topic. It was very well done.
Thank you. Any other questions from anyone else?
Well, thanks for taking the time. I know you're in a busy. It sounded like you're in the middle of a busy clinic or something like that. So
No, it's only the MRI.
Oh, it's been very much
for patients who
appreciated.
refuse to sleep.
All right. Thanks.
All right.
Again,
Okay.
Joyce.
Thank you very much. Okay. Bye-bye.